Hello and welcome to the first episode of this podcast. The podcast is myself, Elliot Greenman, and Alexis Enel, who is an osteopath and owns Euphoria Osteopaths in Tetbury, Gloucestershire. We started it because he was treating me many years ago, and then we started talking more about pain, and he had an idea of a course he would like to put together around pain. And so we started having these long conversations, and they were, for me, really interesting. And I said, look, we're having these conversations anyway. We might as well set a mic up and a camera and then put it out as a podcast. So that's exactly what we've done. This episode, we talk about pain and Alexis' ideas around pain and his understanding and experience of treating people with pain. And yeah, I hope you find it valuable in some way and enjoyable maybe. And maybe you can learn something from it. And maybe you have some questions and some feedback. And if you'd like to like, comment, share, email, engage in some form, then please do. And yeah, I hope you enjoy the first episode.
Perambulations in franglais.
So Alexis, you are from Euphoria Osteopaths in Tetbury, and you also have a clinic in Swindon.
Yeah.
And so you wanted today to talk a little bit about a course that you are in the process, or that we're in the process of making.
Yep.
So why? What is the course about to begin with?
So it's pretty exciting first. Because it's always difficult to put what's in your head on the paper, but put it through videos and all the infographics and the whole thing. I think it's to organize it. So I think the main reason why the course is actually quite interesting is to actually organize people's way of actually approaching pain a little bit. And it's possibly gonna be a bit of a guideline and a framework that people can apply again and again. It's really a bit universal, but quasi universal way of actually approaching it. It's just like, and then I think it's just mostly as well. Why we want to do a course like that is just to have had enough of the pain being something bad. And when actually it can be such an interesting venture, an interesting journey of exploration, of knowing oneself and one's limitation and things like that, really. And I think that's what the current 21st century type thing. We need to know who we are, really, and pain is actually could be quite an awesome avenue down that line, really.
Have you spoken about that? Have you introduced the idea of pain being a useful or awesome thing to any of your customers?
Well, yeah, I think you realize all of a sudden that if you want to kill it and get rid of it, most people are really understanding that, if your ankle is quite painful and you take painkiller, you tend to hide a bit of something, and then they might hurt themselves a bit more, they might damage it more and not have the feedback. So I think people...
Because the painkiller
numbs it a bit, really. So I think you don't really have to introduce maybe a concept of it being really positive and really useful and things like that, but you can tell from patients that there's something a bit underlying it, and they, as much as they want to get rid of it, they want to understand it as well. And I think the series of video and that course, that really introductory course, to start with, will really give people a bit of a new framework to look at pain from a bit of a different angle. And whether, I think the second series of courses will be a bit more practical, because it's a bit hands-on, it's a bit manual therapy anyway. So when we start to show a bit of foam rolling and different technique, myofascial release, a TENS machine, all sorts of, well, we could maybe ask other people to come around and show us a view what they do really, but there's so many ways. But once you apply all those different techniques on the framework, I think it works really well, really, and everybody can, at his own leisure, there's no set way of doing it, there's just what suits you best, really. So your imagination can actually run as wild as it wants to be able to get rid of it, really, basically.
So there's no you said there's like the first part and second part of the course. The first part's like the framework.
Yeah, the framework. Yeah, and a bit the theories. You have to put a bit the whole thing in a context, a little bit, really. Okay, and to contextualize a bit our way of thinking. In the Western world, all those kind of stuff a bit, and how we look at pain a bit, and then how to scientifically and very pragmatically lay the whole thing, and then try to organize it, and how is it we can tackle it, and use our resources a little bit, really, to try to make it something which we can maybe control a bit better, we can enhance our competence a bit better, we can be part of a community of other people, we can have a bit of, it can become quite meaningful to talk about the whole lot a bit, all those kind of stuff, really, and I think it's quite...
And why did you come up with the course? Because it's like you're an osteopath, I've seen you for loads of years, known you for a long time, and I think every time I've come, I've been alleviated of pain. So why are you doing a course instead of people coming to see you, and then
because I've got two hands on it. So I think I'm gonna have to wait to the 22nd century to be able to clone myself and do it for many people. No, it's just the approach I use, and then why not kind of put it to the masses and for more people to be exposed to it. And I think there's a legitimate and a very real kind of demand for those kind of things. We see a bit, with all the different pain-killing medication and all the addiction to opiates that they are in the States especially, which is really an open type thing. But in the UK, I think we are no better. In France, it's exactly the same. I think we rely far too much on opiates and opiate derivative to actually really combat something that doesn't really actually work with it. It doesn't actually work with it. It compounds the problem.
What opiates? Like
tramadol, cocodamol, proximol, Zapain, all the different variation on the same thing, really. Oxycontin, like liquid morphine, like literally, really. And that the whole thing really is so simple, really, but there's two types of pain. The pain is not the same. That's it, really. So there's that acute thing when you traumatology. So you break your freaking face on the windscreen.
Traumatology.
Yeah,
traumatology.
Yeah, trauma related thing. So you smash your face against the windscreen in a car crash. To have a bit of morphine on a drip is actually pretty good. Okay, it's not it's not 17th century on a bloody British or French ship where you have to put a piece of leather between your teeth and a bit of rum, and then we cut your leg with a saw. Okay, so I think it's
so for that kind of pain, for someone who's obviously,
of course, it's awesome. Like opiates are really like, and being able to synthesize the whole lot and the whole pharmaceutical aspect of it is awesome. For acute pain, there's no better. People can control it nowadays. They've got so really awesome thing. The main problem we talk is with chronic pain. What people call chronic pain, actually persistent pain would be even better way of describing it.
Which is pain that's like goes on for
however long.
Yeah.
Acute pain, like you break your ankle, 6 weeks later it's done and dusted, no pain, gone, and you go back running, really, type thing, really. Yeah. But for some people, 3 years later, they've still got pain in their leg, really, somehow. And that's going to be made worse, and your perception of pain is going to be worse the more opiate you take. because on the long run, opiates tend to sensitize your nervous system. You get accustomed to it. That's where addiction
Desensitize or sensitize?
Yeah, well, it makes your brain more susceptible to pain. So your perception of pain gets enhanced.
Oh, so the perception of pain actually increases rather than the effect of the opiate decreasing.
Well, that's
Or is that part of it as well?
Yeah, that's maybe the end result, because you end up taking more opiates. So instead of taking 2 cocodamol a day, you take 6 or 8 or 12 or whatever, how much really. So that's it really. So I think it's a great solution, I'm pretty sure, but not really. And I think it serves a few, but not the masses. I think there's loads of people in pain. Loads. And a reason for I don't know, I think I could have done my research a bit better and then really look online for that type of topic and those kind of things, but I think it's really quite a bit a medicalized way or neurophysiological way of looking at it really. And the whole framework we use is so 1970s. It's really dive into neurons, looking at synapses, which has been used for pharmaceutical use, really. Which neurotransmitter goes between which synapse, and how is it we can block the whole thing, how is it we can desensitize the threshold or decrease the threshold of action potential of the neuron, all those kind of stuff. So it's been used for all the pharmacological way of approaching it, really, in a way. Really.
Those studies that were done in the 70s, you said,
Yeah.
you're using those same studies that have been used for
And the whole model they put up together, the ascending pathways, the inhibitory pathways, the excitatory and inhibitory descending pathways.
So they've used it to make drugs.
To look at physiology, to look at what the spinal cord was doing, all the deep tendon reflexes, all the sensory input, all the different fibers, the diameter of different fibers, all the column going up and down the spinal cord, all those kind of stuff, to get an idea about the geography of it and the way it functions, the length of neurons and axons, all those kind of stuff, really, where the nucleus of the nerve, the neurodegenerative condition, all sorts. There's been so much beyond that, really. But the whole thing is being used for pharmaceutical use a little, and there's not really much practical type thing. There is, in a way, because people use TENS machine, people use acupuncture, people use myofascial release, people do stretching, people do osteopathy, physiotherapy, chiropractic, whatever. There's plenty. They do go to the doctor, hot, cold. There's so many things, really. But I don't think it's a bit like throwing going grenade fishing, really, in a way, really. It's just like we need to be a bit more surgical on the whole lot and make it a bit applicable to oneself. And I think it brings back the whole thing to the individual and what suits them best, in a way, really. Okay.
So within this course, there's lots of science, I guess. Or
People will be able to check the science if they want, really, at the end of the day. I've not invented, I've not coined anything. I've not even put it together, because it's been put together for us, really. I'm just using it, really. And I'm pretty good at using it, that's it, really. And I'm pretty good at putting it forward to people in order for them to organize a bit how they go about doing things with their treatment, in terms of stretches, all those kind of stuff. And there's a bit more theory behind it, because sometimes I don't really explain all the shenanigans behind it. Really.
All the detail. But I mean, that's kind of tricky, isn't it? Can be quite complex. So is this only with regards to I know we've spoken quite a while ago about the different conditions that an osteopath is allowed to say that they can treat, or at least that the ASA, the Advertising Standards Agency, have outlined. Is it only for those things, or do you think it could apply to other long-standing?
Well, I guess it's for pain. So
anything.
I think it's pretty. I think pain. So like pick,
Yeah.
pick and choose.
But
pick and choose.
and
Everybody.
so any persistent pain,
Anything that you can't really get rid of, if you really look at it from a bit of an organized, rational, pragmatic fashion, scientific fashion, and you really apply the different techniques in that way, I'm pretty sure you will be able to dial down things for sure.
But what happens if I thought about this a few times where it's like I've got a lot of friends who have had different types of long-standing pains, and they've gone to doctors and they've been like, do this, and they've been able to reduce the pain a little bit, but then it comes back, etc., etc. And I know you're saying like with persistent pain that it can. I think I'm right in saying it can come and go. Like sometimes the pain is going to be quite mild or not noticeable at all, then it's going to come back. Yeah. But what happens if there is actually like a structural, a real structural issue that's making, sometimes you're quite happy and I guess like adrenaline or whatever else is running through your body, so you're not feeling the pain. But then I don't know, 2 days later when everything's kind of dialed down a little bit, and then all of a sudden you're able to relax, and then you focus on that pain again, it comes back. But what happens if there's actually like a structural thing?
Well, if you were in better and then worse and then better and then worse, I don't think there's much the whole role of the structural problem is not really very relevant.
Okay, so there might be something.
You possibly mean about cancer?
No,
you mean about some kind of like some weird.
Let's say, for example, like loads of people have knee issues, right? So what happens if
their meniscus is being damaged?
Whenever I go running, I get like like IT band issues, and then I can be like. I mean, I guess that's a bad example because it's generally only like a week or two before I leave it, before I go running again. So I don't probably let things heal. But feels like there might be like something structurally wrong with my knee, or it's like off slightly because maybe I'm tight, short, long in a different way, blah, blah, blah. How do I differentiate from that as like an ongoing issue to something?
Is it painful?
Yeah.
Yeah. Okay. Well, I think the whole stuff will work or not.
Yeah.
And if the least it works, the more structural the problem is, and the more structural the cause of the problem is, and the better it works. But we're not talking about people who just sprain their ankle. Really, we talk about people who've been in pain for a long time, who've seen their doctor, who've seen physios, who've seen osteopaths as well. They might have even seen me, in a way. All those kind of stuff, really. But we want to have a bit of a framework we can apply on the whole lot. Yes, of course, it's not diagnostic, and I'm pretty sure diagnoses are not really 100% nowadays even, okay? And there's a lot of thing out there in terms of, people are like, oh, I've got bad back and thing, and then they end up, oh, but the doctor doesn't want to do an X-ray and thing, and then I want to know what's happening and thing. So people really want a diagnosis about the whole lot, really. Yeah. And they're in loads of pain, and then we've got an X-ray and there's nothing wrong.
Yeah. And then they need an MRI or something.
And then they need an MRI, and then there's nothing wrong.
Is that just because...
There's nothing structurally wrong, but they're in shitloads of pain still. Yeah. They're in still loads of pain. Yeah. And therefore, there's no correlation between the structural problem and the amount of pain you're in. So you can have really bad wear and tear in your lower back and have no pain whatsoever and function perfectly.
Yeah, I've seen studies where... Yeah.
Yeah. And then some people have got no wear and tear whatsoever, and they're crippled. Okay, so that's the whole thing, really. So that's not the objective of the course. I'm not wanting to diagnose people and to know exactly what's wrong with them. I want them to be able to manage their pain a bit better and in a more intelligible fashion and in a more experimental fashion or experiencing fashion. Type thing. They can really play with a whole lot. It's fun. It's a bit of an interesting concept for pain.
It's
really.
Like it's a journey that people.
Yeah, journey. That's it.
Obviously, it's not going to be loads of fun, but it's hopefully going to be interesting. Yeah. And I know from the things that I've learned from you and the things that I've learned from other sources of different things, it's like it can be quite interesting. But I guess it's kind of tricky because a lot of people want a diagnosis, don't they?
Of course.
Because then they can say.
So nothing can move anymore, and then it's fixed, and then that's it. I've got that condition, and that's it. I am depressed. I have multiple sclerosis. Well, yeah, maybe. But there's much more to you than your multiple sclerosis. Mm-hmm. There's much more to you than your depression. You are so and so, and you suffer from depression. Yeah, I can really understand that. But you're not depressed.
Yeah, you are not depression.
Yeah, you're not depression. You are not your diagnosis, really. But people like to be defined with their diagnoses. It's fine, and obviously they're not gonna come and do the course.
Well,
we don't have to rock people's boat. I'm not trying to challenge a whole lot. It's really very clear, very scientifically proven. It's well-trodden paths. There's nothing to challenge about the whole lot at all. Mm-hmm. It's just like that's how it is, basically. That's how you function, basically. Why not tap into that and understand a bit how you go about doing it, really? And if you're not happy and you want to be diagnosed with a whole lot and take more painkillers, well, that's an option as well. That's the whole thing. It's a freedom of doing. It's a volition you've got. You've got free will, or freer will, like I like to say. Really, you can do whatever you want. If you want that, no problem. No problem. If you can't sleep at night and you have to take a 3 tramadol at 3 o'clock in the morning and you're happy with it and you want that to carry on, so you don't do anything and you don't change. Yeah, well, there's going to be plenty of tramadol. People are quite happy to sell it to you. And that's it, really. Well, until the NHS asks you to pay for it, and then maybe it will change a little bit as well. So once it's not on repeat prescription, and you're going to have to fork out the bill at the end of the day. Because, we read a little bit, and both of us read a little bit with Noah Harari, a little bit with Homo Deus, a little bit, really. Not a little bit, but with Homo Deus, and the main divide is going to be between people who have technology, who are going to, for their Parkinson, are going to be able to have a deep brain stimulation type surgical procedure, who are going to be able to afford it, or, I don't know, the L-DOPA, or all those kind of stuff, which is one fantastic kind of advance in a way, really. But how long is it going to be on the NHS? In a way, really. How fast is it going to go private, and how you're going to have a complementary health thing, a bit like on an American thing. Well, that's a bit political type stuff, but nonetheless, okay? And how is it we can do, we talked about the genetic determinism. Oh yeah, but there's nothing you can do about it, and if your gene is like that, you're going to have Parkinson, whatever you do, you're going to have it. Okay, great. That's an interesting way of doing. But actually, we talk about epigenetic nowadays, and there's something a bit above it. And then we know we inherit only 50% genetics, and we inherit 50% behavior. And I guess the main thing with people who might be predisposed to having neurodegenerative thing is to maybe manage their stress a little bit differently, and then maybe look at the research a little bit, and maybe there's certain supplements or things that you can exclude from your diet as well. All those kind of stuff that we know about, really. So, in a way, yes, it's for an individual, but it's for a bit maybe on a long-term basis a little bit to try to enable people, because a Coca-Cola bottle, an empty Coca-Cola bottle can do a very good foam rolling type thing. You can work your plantar fascia really superbly with it. You don't have to buy a fancy foam roller at all, really. If you know a bit what you do, I bought a TENS machine the other day on eBay for bloody 15 quid, 14.99. Like, you can't even go to the pub and have 3 pints for that kind of price, really. So that's the whole stuff, really. So nowadays, some of the stuff doesn't have to be expensive at all. The management is awesome. You can really do quite a lot and it's a bit of a populist or popular or mainstream type way of doing, really. And the more people know how to manage their pain.
What's a mainstream way of doing it?
Well,
getting the surgery or getting.
Well, that's the thing, really. Doing it yourself should become a bit more mainstream. Yeah, that's the whole thing.
Yeah,
really.
And I think it's becoming more popular, right? To do it yourself, but there's a lot out there, and there's
a lot out there. There's lots of information, lots of different ways of doing, and everybody does a whole lot, but doesn't expose a bit their framework. It's great to be able to do the whole lot, but what's not science behind it, but what's the rationale behind it? Why would you want to do that like that, really?
So what's different between the course that you're doing, like just talking about the first part, to other courses out there? Because there's quite a few that I've seen that address pain, and we've spoken about them, like like Naudi Aguilar's work on functional patterns, which is great in lots of different ways. But what's different about your course to other courses that you've seen?
So the whole thing helps you to actually get to grip with the part of your body that is actually a problem, and to relate it with different layers a little bit. So Naudi does very good functional release type thing. It's very much like a structure governed function, or function governed structure, or it's a bit interrelated, the structure and the function, which is very osteopathic principle in a way, really. So the shape of your radial head is going to allow for only a bit of internal and pronation and supination in a way, really. And because we are lucky to have a ball on the elbow, as well as a supination and pronation, we can actually have an flexion extension with the ulna as well. Really. So the structure and the function are quite linked together in a way. So we can do that like that as well. But with a framework, you don't have to repeat the whole lot. You can really look at what is the problem yourself. You can find the information pretty easily, and it's pretty straightforward. It's well confined to the remit of something, really. The dermatome of C5, there's no 75,000 ways of doing it. There's only one thing. If you're put together the same. If you're not conjoined twins, or okay. There's always exception, of course. Okay. But the dermatome of C5 is that same. The muscle that C5 is going to supply is for everybody the same. Okay. There's no gender discrimination here at all. Muscle are supplied by the same nerve for everybody, whether you're a woman, a man, a transgender, a gay, whatever. It's all the same thing. Okay. So there's no variation. You can't really. You can go online, C5 dermatome, bang, and it comes out. That's it. It's just there, and it tells you which muscle comes out. So therefore, you know which muscle is associated with that, and then which organ can be related to that as well with your autonomic nervous system. So it's super easy to get access to all the information. You can double check the course. You can do more research. You can go in more depth about the whole thing and stuff. Well, because that's the whole physical, that's the peripheral modulation, which is the main thing. That people know are there, really.
So the physical side of it,
whether it's physical, actually, is not really. It's nonetheless a brain experience anyway. So which is, I mean, really. So the central modulation, nonetheless, is really what it's on about, and that the main moment in the last 15, 14. Well, I guess I came across that 5 years ago or something like that. The human givens approach and expectation fulfillment theory of dream, Joe Griffin coined, who's actually a psychologist, actually. Is amazing, really, and he puts the whole stuff completely together, and you understand a bit different how your brain is actually like people are gonna be in bed and in loads of pain, but when they're at work in front of their computer, well, they are not too much pain. So when your attention is your pain is able to come really close to you and completely overbearing, and then it can go really far. Okay, so we're talking earlier on about the whole stuff variating and things like that at times. Well, I think it's really to do with that. Really, it's how your attention, how you focus on it, and what makes you focus on it. So you need to be able to understand a bit the whole lot and get the mechanism there, because there's another algorithm. Again, there's another loop that goes on and on from bits and bobs. So once you will be explained a little bit how it all works, it makes pretty much lots of sense, really. It's not super rocket science. That's where, the whole theory is brilliant, really, The theory of relativity, E equal mc square, everybody knows it, is the mass and
it's been tested.
Times the speed square. Really, it's just like completely bonkers. The way it's been tested around Earth, on satellites, for all the different effects, like orbit of Mercury, the whole variation of it it's 1915. Since 1915, the last 100 years, all the scientists are at work to try to disprove the whole bloody theory. And it's so elegantly put. The whole expectation fulfillment theory of dream is really elegant. It fits the whole package really nicely. I think it's going to be difficult to find a theory
That's better.
Yeah. And who tends to, we were talking about C5 dermatome is just the way it is, really, when it comes to addressing people's mind. And all the psychoanalytical way, all the historical thing with Jung and Freud, and all the whole investigative type thing, and the interpretation of dreams, and all those kind of things. It's almost like there's 900 and ish ways of actually approaching people's brain, really.
Yeah.
When actually maybe one way would do quite nicely, actually. Thank you very much.
Or at least a continual framework.
One framework that we can apply, and then. But when you get the APET, the activating agent, the pattern matching, the emotion and the thought, and you get it in that sequence, well, it works pretty well, really. Mm-hmm. So you can do your clinical hypnotherapy, a little bit like that, and then but you need to find out what's the activating agent. That's the whole thing, and you need to understand what the pattern is, and the pattern matching is. You need to understand which emotion you get, and then what's the thought behind it, really, or what sensation you have, and what cognitive process you have after that, really.
Whereas the idea behind that is that most people obviously don't think about the first three and then go straight to thought, right?
That's it. A little bit, yeah.
And so this is like breaking it down a little bit more.
And in a very algorithmical fashion, because the whole limbic system, so a lot of what we hear nowadays is your limbic system and your reptilian brain is kind of dictating a bit your life.
Your reptilian brain?
Yeah, reptilian brain. Oh yeah, primitive brain, like your amygdala, your hypothalamus, your whatever. The whole core of it, not the cortical part. So flight and fright, PGO strike, so pontogeniculo-auricular strike. You see something in the whole lot, and it gets your attention straight away. So you actually turn your head and your eyes, and then boom, you get to the whole lot. Is it danger? It's not. If it's danger, bang, you leg it. You don't really think about it. It's all been ready, put together. Your heart rate, the dilation of your blood vessel into your muscles, the constriction around your gut, all the whole lot, the adrenaline to completely focus you on the whole lot, all those kind of things, really, okay?
So it's an evolutionary response, and that's
really, really well put together, really well adapted.
Developed over a long time.
For the last 40,000 years. With 2019, it's not really super relevant for most of us. That's the whole thing. In your kitchen or at work, there's no saber-toothed lion who's coming to eat your arm.
Or maybe it is relevant, but we need to have more of a control over it.
Yeah, control. I don't think you can really control the whole lot.
Or maybe understanding.
Exactly.
Okay,
You can understand the whole lot, and actually, well, it's a normal thing to have a little bit of a flutter when you're introducing something, and nobody can see your heart beating. Nobody can see that your mouth is dry until they put their finger in it. Your mouth is dry, type thing, those kind of stuff. So we get a little bit of a movie in our head.
Oh, so we can hide these responses from people. Is that what you're saying? As in,
well, most people who are depressed, can you tell they're depressed?
Nope.
No, exactly. Most people who've got anxiety or problem with public speaking, you can't see it. Like,
wow, you can in some
yeah,
cases.
Because usually they don't go to public speaking. That's the only thing. But when they public speak, you're like, wow, it was great. Oh, wow, I could not really have done as good as that. When they're actually breaking it, they were really sweating profusely, thinking they were going to be shit and a whole lot, really, when actually they come up really nice, really. Anyway, but So all that is really well organized, and that theory is really very helpful when it comes to actually looking at pain and what is actually stressing us, basically.
So you said you came across this like about 5 years ago.
Yeah.
What was your thoughts on it before then? So
I had no idea. I had no idea it existed.
So
people
were. We've spoken before, obviously, and you said, you treat people and then they'll be fine, and then they'll come back in 2 months' time or 3 months' time, and they'll have the exact same issue. And you were saying like that puzzled you, and you were like, So is that the point where you were like, this has to be something more than just? I know you don't like to separate the mind body, but just I guess physical or physiological.
Physiological.
Is that the right way?
Yeah.
So you had absolutely no idea before this model. There wasn't anything that fulfilled it.
For FNAR, for no apparent reason.
Okay.
It wasn't really kind of rocking my boat too much. But people are telling you, I hurt my back.
People said that.
Patients are saying, I don't understand why I have not done anything out of the ordinary. Like I didn't dig a trench, I didn't fall from the second floor on a brick, but I feel like like my back is completely bad, really. Okay, and that's really the pattern matching again. So we were talking about. So we can talk about it from a behavioral point of view a little bit. So you're mugged, somebody wants to nick your wallet, they beat you up a little bit to a pulp nicely, they kick you a bit on the ground and saying a lot, you're on the pavement, it's a bit wet, it's dark, and the street light is flickering vaguely type thing. You go to the police station, you do your stuff, you go back home, you tend to your wound. 2 years later, it's a long past memory. You're with some friends in London, you're having a good time, you're going clubbing, and then you're in the street, it's a bit wet, the whole stuff, and the light is flickering, you're having a massive panic attack. And you've got no freaking clue where it's coming from. But your brain is like, there's that. Last time, all those three elements were almost there. What was happening? Okay? So, bang, you've got the panic attack, it prepares you, and you're completely oblivious because you don't really have the memory of the whole lot fresh in your mind, being like, oh yes, I remember, the light was flickering, and then the whole lot, you've got no idea, you're having a panic attack, the world closes in. That's one way. Other pattern matching, and a crude pattern matching, is the baby breastfeeding. The baby comes out in the world, and he's going to breastfeed, okay? Well, if the teeth of the mum had to be a certain size, a certain color, a certain shape, and a whole lot, most babies will be dead. Okay, it's because there's so many breast size and nipple size and aureola size and all those kind of stuff. There's even plastic ones we can give to the baby, and it's almost the same, and it can pattern match, and the pattern matching is crude enough in order for the whole stuff to be, you can accommodate it. The bird building his nest, he's going to use a copper wire. Okay, he's going to use other things that are not branches, but it looks like one, and it does the trick, and it does the job, and it's fine.
So that's like a positive pattern matching.
There's a positive. Well, when the light is flickering, and then you have a panic attack, it's quite positive because beforehand you lose your arm, the saber-toothed lion comes out of the bush, and he eats your arm, and you manage to survive. The next time the bush is wrestling, you don't bloody hang around to see what's coming out of the bush, really, okay? If it's a little piglet or a saber-toothed lion again, okay? Because you might not lose the next arm, you might be dead. So that's pretty useful. It used to be useful. That's why we were mentioning before, okay? So, and there's a definite one with pain and physical pattern and firing sequence and potentially maybe the whole emotional environment. So the first time you do the whole lot, you're taking the pack of water out of the boot of your car and it's really far, and then your missus is giving you a earful a little bit because you've forgotten the agendas and you've bought some vanilla instead of the chocolate and thing, and then you turn and then you leave the whole you do your back in pretty badly, you do your facet, it's really irritated and stuff. The next time you're in the toilet, 6 months later, you're in the bathroom, and then you're bending over to try to reach behind the bloody thing, and your missus is coming and she's telling you, she distracts you, you turn, blank, and then your back goes like it did the first time. That's called pattern matching as well.
Okay.
And that's for no apparent reason. And because it's a crude pattern matching, you don't have to have exactly the right sequence of event in the right fashion, in the right way.
But also because it's quite unlikely that someone's going to be able to. You have to notice lots and be quite aware of all of the things that happened originally. Then what's happening now.
That's it.
Pattern match. Even then, it might be too crude for you to.
Too crude to be able to relate the two anyway. So that's not the whole, But nonetheless, there's a crude pattern matching, which is actually quite a useful thing. And then you come here, you're in loads of pain, and you're like, well, had I fallen from the second floor on a brick on my back and be in that kind of pain, fair enough. But just leaning in the bathtub, trying to clean it, and then turning around and having that kind of searing pain and the whole lot, there must be something wrong with me. Structurally, they must be buggered. I deserve to have an answer, and somebody needs to give me an MRI scan right now, because I'm in lots of pain. The painkiller don't work, all those kind of stuff. I'm in agony, I can't function, and Okay, that's really pattern matching, and you've actually not damaged yourself at all. It's your body who's protecting you, because last time you did that thing in the hair, you hurt yourself. And this time around, just in case you hurt yourself, the whole thing goes into spasm to prevent you from moving. And there's one thing I know from experience: when people are in a lot of pain, they don't move very well.
They don't move very well.
No. When your back seizes pretty much and spasms, you don't move very well. And also don't think very well. You don't. You think like a proverbial idiot. That's another way. That's all the whole thing a little bit really. So
this first part of the course addresses some of that. Okay.
Yeah, it's good eye opener a little bit. It gives us a bit of. It gives all of us a bit of a step back a little bit, and maybe to try to look at the whole problem a bit from a lateral thinking way of doing a bit, really, which is really important. I think there's too many people in pain, and the way it's approached is far too crude and too simplistic, in my opinion, and it's possibly from lack of knowledge about the mechanism, and it doesn't have to be very intellectual. It's really quite plain and simple way of putting it. Once people are explained, it makes complete sense. People definitely.
And have you already explained this first part of the course to some of your clients?
Yeah, of course. I work with that all day in, day out, really.
Yeah.
About that model, really.
Yeah.
And imagine I treat animals as well, really. So the whole cortical aspect of it is not there at all.
What animals do you treat?
Horses. Just horses and dogs.
And dogs?
Yeah.
But what's the difference? Were you saying it's like that? But
they don't have a cortex. Yeah. And they are not conscious of being conscious. They're just conscious.
And so they don't hold on to. They don't have the pain that lasts for 6 months, a year.
Yeah. Well, yeah. Maybe they have. In some of cases, but it's definitely not mentally held a little bit. And remember, horses are not left on their own too much. There's riders around. We impose a bit the whole thing on them, who's not helping them to get out of the pattern and thing. But I was trying to illustrate a bit the whole cortical, cortex-related aspect of it. We've got a big cortex, and it's very interesting, but at times it plays us fool a little bit. And I think we need to be able to step back to just go back to basics a little bit. What's the mechanism at play? Where does it come from? How does it reoccur all the time? How is it I can actually approach it a little bit, really? And what is an ordered way of actually dealing with it very pragmatically and quite simply, basically.
And that's where you came up with pulling some of these things together.
That's it. Into the course. Yeah, into the course, Because we are manual therapists, after all, osteopaths, but we talk to people as well, and people talk to us, so we get quite a good insight on lots of things. It's a patient of mine who actually mentioned to me about the human givens in the past, really. So really, you learn so many things from patients all the time because they are really well informed on loads of things that are of their concern, really.
Because pain can be quite a good motivator.
A very good motivator, indeed. Yeah, no doubt. We talk about that a bit in the course.
So the first part of the course is that, and then the second part of the course
is how to apply it to body parts.
To the various body parts?
Yeah.
Okay.
So shoulder pain, hip pain, sciatica, knee pain.
Is that just an expansion of the first course?
Yeah. And then you'll have a bit more diagnosing type thing. You'll have more techniques, you'll have more hands-on, you'll have to really get to grip with the whole part of your body and how it functions, really. That's where, the whole problem about the tissue causing pain gets a bit of a problem, really. We don't need to be anatomists. We don't need to know that it's the anterior part of your lateral collateral ligament in your ankle is fine. We know this is fine. No problem. But what is your ankle meant to do, and how is it we're going to improve that? How is it we're going to go about which dermatomy is, which muscle crosses that joint, which organ is related to all that? Really important. Okay? And then what it prevents you from doing in order to work with your higher centers a little bit, in order to de-stress a little bit from the whole situation, really.
And who's the course for? Is it for anyone?
Yeah, anyone. I'm pretty sure. Yeah. I think it's really bad marketing, very bad marketing thing. It's not, it's definitely not for people who don't want to take ownership of their pain. So people who want somebody else. So that's why we should have maybe started the conversation with, because there's really two types of people, really. There's people who want you to actually make them better, and there's people who want you to help them to make themselves better.
There's people who, say that again.
There's people who want you to make them better, and there's people who want you to help them make themselves better.
Okay, yeah.
Okay?
Yeah. So they want to understand and then be able to continually do the things that's going to improve the pain.
Exactly.
Whereas there's some other people who aren't prepared to necessarily learn and put in the work, but they want
somebody to do it for them. So they can delegate the whole thing. People who want to delegate the whole thing obviously will not be our potential subscribers, but people who want to be helped to do the work themselves, they'll be more, I'm pretty sure they'll be very interested to know about the whole thing. So I guess that's the two type of population. After, I guess you need to be able to read and English as well. I could do it in French, I'm pretty sure, but at a later stage, there'll be less franglais accent.
Yeah. But how much, is there going to be much reading? So you're doing some videos, we're doing some videos.
No. It's really hands-on, practical. There's not going to be too much. Well, there'll be a few things to print, maybe.
Of course.
And a few things to motivate you, all those kind of stuff, for you to understand how you can get motivated, how you get bogged down by different bits and bobs, all those kind of stuff, really. Yes, I'd like to think in the second part of the and the body part of the course, there'll be quite a lot. I think people will have to write down a few things, they'll have to think about it, or type it, or whatever, how they want to go about it, really. But there'll be a little bit of homework to do, but not research. You don't have to go to a library.
Should all be there.
Use Wikipedia, should be fine. It will all be there. You might have to go to your recycling bin to get old bottles, but for most of you, I think there'll be a few bottles of wine out there, a few beer bottles or cans that we can use to do a bit of work, really, with.
Cool. And is there anything else you wanted to say about this course on pain, the Euphoria course on pain?
Yeah. No, I think it was a real pleasure and pain to actually do it.
Yeah.
So, and to stay motivated to be able to do it and to come up with the right way of putting it together. I think it was really quite a challenge as well. But as I think the more people know about that kind of way of doing, the better, basically. And it can be expanded upon, it can be restricted, it can be done in many ways. It's just not directive one bit. It's just the way you function. So that's the model we use.
Yeah, so it's just learning about that framework, and then you can kind of build stuff on it.
On top of it, as much as you want. Yeah.
Cool. Sounds exciting.
Yeah, definitely.
Cool. So should we end it there?
Yeah.
Should we finish it there?
Yeah.